Sure.
Pretty good. I feel like I have my goggles out.
Good afternoon, everyone. I think we're getting started. Welcome to everybody that is here in the room and online. My name is Sandy Chibulius. I'm a professor in the NEAG School of Education. I am so delighted to introduce our speaker today. Yay! I'll tell a very quick story before I introduce her, but we've had her on a list since pre-pandemic, I think we were saying, to come in person. And when she showed up on the list this year, I almost forgot about it. It's been so long. We've been so delighted to be able to sponsor Dr. Szucs to be here. Leigh, can I call you Leigh?
Yeah.
Leigh is a senior health scientist at the Division of Adolescent and School Health, otherwise known as DASH. I'll just call it DASH.
Yep.
Lisa's Division of Adolescent and School Health at the CDC. She's all about sex, right? And health education. Right? Let's talk about it that way. So her research focuses on evaluating school-based health and sexual health education programs aimed at preventing STIs, including HIV, and unintended pregnancy among adolescents. She has been a huge proponent in technical capacity building across the United States, is always circumventing the United States, I think, and working with different districts and schools and states in their work to create healthy spaces for our teens. And I'm so delighted to have you here.
Thank you.
And I'm going to turn it over to you.
Awesome. Thank you so much. Yeah, that was great. Can y'all hear me in the back and online? I'm like, where's the camera? Where do I look? Well, thank you so much, Sandra. It's such an honor to be here. As was mentioned, my name is Leigh Szucs, and I use the pronouns she, her, hers. And I am a senior health scientist in the Division of Adolescent and School Health at CDC. I'm like, we call it DASH. I just default to saying DASH. At CDC in Atlanta, and as was said, I love and focus on all things sexual and reproductive health toward the promotion and prevention of both HIV, STIs, unintended pregnancy, as well as a number of other risk factors related to health and well-being of young people. So I'll talk a lot about sexual health this morning, just in some of the content that I'm going to provide, but happy to answer questions about other content areas, and if nothing else, kind of take names, emails, connect to other folks that are within DASH and the agency to kind of help promote and further the work that you're doing. So this is my first time in Connecticut, so I'm freezing my buns off, but the campus is so beautiful, and just thanks so much for InCHIP and everyone for hosting. It's just been an absolute privilege and honor. So we bring warm greetings and welcomes from Atlanta. So this is the talk, right, promoting adolescent sexual health, and as I said, the prevention of STIs. Today on content and implications for schools. So at CDC and DASH, we are a schools-focused division. So we fund directly to K-12 schools in the US. We provide support through technical assistance and capacity building, and all of the research that I'm going to talk about that I have conducted and that others do in my division are all focused on the K-12 setting. The caveat with that is I will say we love schools. Schools are not the only place where sexual and reproductive health issues affect young people, right? So we know schools and communities and faith organizations and clubs, and there's lots and lots, social media, technology, there's lots of areas in which sexual reproductive health is impacted. It just so happens that for us at DASH, and for me in particular, schools is kind of the secret sauce, if you will, right? So here's where we're going. I'm gonna try to talk pretty fast, and I'm happy to share the slides at the end of the presentation. And again, we'll have some time for Q&A and can follow up. I would love to continue conversations, but we're going in kind of three main sections. First, we're going to talk a little bit about what we know about adolescent sexual health. This is not a new content area. Every person in this room is a sexual being that walks around on the planet, so we know a lot about adolescent sexual and reproductive health. So we'll talk a little bit about data at the beginning, then we'll talk through specifically our approach in DASH to adolescent school-based sexual reproductive health. So kind of what we do with our funds, what our research evidence has shown, and what we kind of ask school districts to do with our monies in order to address, again, HIV, STI pregnancy, and a related set of outcomes. Then we'll talk about tools and resources. I think it's interesting for folks, if they haven't had a kind of first-time interaction with CDC or a person from CDC, to kind of orient to two main goals. So at CDC, we are a science-based, science-forward organization, right, that works to promote and protect the health and safety of all American people. And so we do that in lots of ways, but I think two of the main things that are important to note is that we do that through our science, so through our surveillance, through our providing information and data in accessible formats to the general public. We also have a really big focus on translation and creating tools and resources so that people can use the science and data that we create and that our partners collect and create to do something with, right? So to impact public health practice. So I'll talk a lot about data, but I'll probably also talk an equal amount about the tools and resources that we make and create for schools so that they can use the information that we collect, again, to help young people. And then we'll have time for Q&A. So that's kind of where we're going. So again, what do we know about adolescent sexual health? Again, this is a long and seasoned area of inquiry. I'm not the first person that works in it. CDC is not the only entity that is in the sexual reproductive health space. Folks in this room are working in that space, but we do know quite a bit. And for us, when we start thinking about what we know about adolescent sexual health, we always start with what are our data sources, right? So for us at CDC, we have two primary adolescent data sources, one of which is the YRBS. So raise your hand, anyone familiar with YRBS, youth risk behavior? Yes, okay, it's like when I see them in the wild, people that know about YRBS, it's great. So we've got youth risk behavioral surveillance. We also have another primary surveillance system called school health profiles. Raise your hand if you know school health profiles. Okay, we need more people, but I'm glad to know we have a few. I think YRBS is kind of the sexiest, most popular thing that people know about DASH, which is a surveillance system, obviously, right, that captures youth risk behavior and experiences. School health profiles, to me, is kind of maybe the more exciting one. It captures school policies and practices. So what schools are doing or not doing in order to promote the health and well-being of students, staff, communities, families, et cetera. So these are our two primary surveillance systems, and I'll show you some data from each of these two. So in case you're curious, kind of who participates in YRBS, again, this is one of our flagship surveillance systems. You can see here on the left-hand side, this is the participation map from 2021. So YRBS is a biannual survey administration that is done across the United States in a nationally representative sample. And in 2021, the purple states are states that received representative data for all the students in their jurisdictional state. The light gray, light purple is California, so they participated in 21 but did not receive representative data. And then you can see the white states and territories, or just states, are folks that did not participate at all in 2021 YRBS for the high school administration, okay? We can talk at a later date about what happens. We know that the landscape around YRBS participation is changing, and so we can talk about that in a little bit. But this is what we had for 2021 high school YRBS. We also have a middle school YRBS version that is administered at the same time in the 6 to 8 grade range. And you can see there we have far fewer states that participate in the middle school YRBS administration, but collects a similar type of data, right? Youth risk behaviors and experiences among just younger populations of students. The other thing to note is you'll see the little orange dots and the kind of call outs around the US. Those are school districts that also participate in the YRBS data administration as a function of receiving our funding during our 5-year cooperative cycles. So, and I'll talk about our programmatic approach, but we currently fund 28 school districts, large districts across the country, to do a number of activities, one of which is surveillance. So you can kind of get a flavor of who is collecting data on our last administration. We're actively in the field right now collecting 2023 YRBS. So we've got school districts that are collecting this week, right? And we'll collect into the early spring, and then the 2023 data will be made publicly available in 2025. So there is a bit of a time difference, or a lag, I guess, but data processing, surveillance, it's a slow-moving train, but we're excited that the 2021 data is available. So if you haven't had a chance to look, or if you're just curious about surveillance data from 2021, I highly encourage you to check out the Data Summary and Trends Report. So as the name would suggest, this data presents both prevalence estimates from 2021 collection as well as 10-year trends. So you can see what's happening with regards to adolescent sexual risk behaviors over a 10-year period between 2011 and 2021. And this is freely available on our website. And I will show you now some of these data, right? So if we're thinking about adolescent sexual reproductive health, right, one of the main risk behaviors that we do track is currently sexually active, right, which for us at YRBS is defined as having sexual intercourse 3 or more months prior to the survey administration. So these data are from high school students. So what you can see over the 10-year time period is that students are reporting less currently sexually active status, right? So both in terms of male, female on the left-hand side. We also are interested in looking at what's the 10-year trend by race ethnicity. So kind of are students reporting more or less, and how does that differ? And we can see that across all of the racial and ethnic groups that we identify in our sample, which is 5, we are seeing marked decreases in the report of being currently sexually active. So again, when we think about risk reduction and preventing STI, HIV, and pregnancy, right, the less sex students and young people are having, the potentially less risk that they might be exposed to. So these are interesting things for us, again, to think about when we're designing programming or thinking about messaging around education, services, and environments for who's actually engaging in sexual behavior. Another variable that we are very interested in, and maybe some folks also might be interested in, is condom use, right? So among our currently sexually active students, we look at prevalence both in terms of 2021 and then the 10-year trends. So among students that are sexually active, we do see a decrease in condom use at last sex, which is not great, right? We want the trend to be going in the other direction, but we have seen some marked decreases among male and female respondents. And then on the left-hand side, we also see some differences by sex, race, ethnicity, and also sex identity and sex of sex contacts. So we can see that about 52% of all the students sampled in 2021 reported condom use at last sex, with some statistical differences, again, by race, ethnicity, identity, and then sex of sex contacts. So these are some data visualizations that you see that are in this data trends and summary report that, again, kind of help us start to understand not only point in time data, right? So from 2021, what are our estimates around sexual behavior, but also where are we seeing the trends go and how might we use that trend data to, again, help with programming, to help with future research studies, and to think about what are the needs of the populations that we are trying to reach through school-based interventions. Another really important piece for us is certainly condom use, but it's also testing, right? So we have variables in YRBS that collect information about STI and HIV testing, and we're just highlighting one of the two kind of flavors of testing here. We see that there is a huge decline in lifetime HIV testing among adolescent populations, right? And so I know folks in my division, as well as in the division of STD prevention, the division of HIV prevention, people are really grappling with this issue of testing and screening as a mechanism for both the prevention and then future treatment and linking students and young people to care for not only HIV, but other STIs or related sexual and reproductive health issues. So we are really concerned with these kind of suboptimal rates of HIV testing. We see a similar pattern with STI testing, although the estimates are a little bit higher. They're still declining overall by male-female status, as well as over racial and ethnic groups. So these disparities are persistent. And as you can tell on the right-hand side, right, there is a big gap in kind of who is testing and what their prevalence of testing has been over time in these self-report data. So again, I think when we're thinking about reproductive health, testing is a component of this work, and our data are unfortunately moving in the wrong direction with regards to testing. Another kind of data point that might be interesting is, so of course, right, we had the COVID-19 pandemic, and that really, I think, right, turned the world on its axis. And for us, we were interested in trying to understand what were the impacts of that or potential impacts on sexual reproductive health. And so we published a paper, an earlier MMWR this year, that looked at the differences in the estimates of sexual behavior reported in 2019 and in 2021, right? So we were trying to think about basically the pre-COVID and then during COVID, kind of what was happening with sexual behaviors among young people. Again, this is using a pooled analysis from YRBS. So we see a couple of things. You can see in the top third of the chart, right? Things moving in the wrong direction are testing again, right? So we saw decreases in HIV testing, decreases in STI testing among currently sexually active students. We also saw increases in no contraceptive use amongst currently sexually active students with an opposite sex partner. So not only were students in this sample reporting less testing, they were also reporting increases in no method to protect against contraception and pregnancy, right? So that's no shot, patch, ring, IUD, withdrawal, some other method, nothing, which from a disease and pregnancy perspective, right, is really problematic. So they're cross-sectional data, right, because they're 19 to 20, so we can't draw any kind of causality or any temporal explanations, but we do know that this non-contraceptive use is alarming to us. We did, however, though, in this analysis find that IUD and implant use was going up during this pandemic period, again, pre and during, among currently sexually active students. So you can see there it rose right from roughly 5% to about 9%, which we're excited about. That probably also makes sense though, right? Because you have these long-acting reversible contraceptions that don't require routine healthcare services. So if a young person was unable to get to a provider or didn't have access to a healthcare provider and they had one of these longer-term methods, that may have necessitated that they didn't need follow-up care. So we're not surprised by that, but also encouraged that IUD and implant use did increase during this period. And then we saw no change in the condom use variable. So again, condom use at last sex, as well as no change in some of our other contraceptive methods, right? Shot, patch, ring, and birth control pill during that time period, again, among currently sexually active. So again, trying to give us a picture of what might have happened during the pandemic. We are always continuing to analyze, and it'll be interesting now that we're kind of right in this pandemic recovery period to look back and kind of do some additional analysis. Do we see differences now, for example, between 2021 and 2023, right? And then 23 and 25. So we know that the pandemic was disruptive in many, many, many ways for many people. And we see that in these data here specific to sexual reproductive health care. So last thing I'll note about YRBS, has anyone ever used YRBS Explorer? Dr. Russell, our one lone user? Okay, great. So if you haven't, so if you're interested in YRBS, right, some of these data are like, oh, this is interesting to me. I want to check this out more. Highly encourage you to Google, or you can go on our website. If you type in YRBS Explorer, you'll get to a landing page that looks like what you see on the right-hand side. So what this is it's an interactive system that allows you to select and dig into different variables that are captured in YRBS. And so you can see there on the left-hand side, all of the kind of health domains. So I'm always interested in sex behaviors, but you might be interested in physical activity, nutrition, what else? Dietary behaviors. You can click on that domain, and then it will populate what you see on the right-hand side, which is all the variables that are related to that domain. So you can look at, right, in the sex space, we can look at ever sex, we can look at forced sex, we can look at contraceptive use, you can look at condom use plus contraceptive, right, or a dual use variable. And from YRBS Explorer, you can export charts, you can export PowerPoint graphics. There's a lot of usability to it in terms of being able to kind of explore data. The other really interesting thing about YRBS Explorer is that you can look at kind of levels of data, right? So you can look at national estimates, which is what I've shown you here. Some of these data slides are national estimates. You can also look at state estimates. So if you're sitting here going, well, what are the high school students in Connecticut doing? You can find out from YRBS Explorer. So you can stratify by the state. You can compare states. So if you're interested in Connecticut versus Rhode Island or Texas versus California, you can do that state level stratification. You can also look at districts. So it's not every district in the country, although we wish it was. You can look at district level data as well. So you can see, for example, like we fund New York City. So if you were curious to know what students in New York City public schools were doing, you can get to that level of granular kind of district level data as well. But again, I encourage you just to play around with it. It can do a lot of cool visualizations, and you can do some kind of basic analyses and do some comparisons, again, to kind of answer some questions about what are students doing nationally, what might they be doing in my state, and then even to the extent available, kind of what's happening in a local school district. Okay, the other data source that I mentioned was the school health profiles, which again, people are usually less familiar with this. This is also a biannual survey administration to a sample of secondary schools in the US, and it's conducted in every other year. So we have like a YRBS year, then we will have a profiles year, then we have a YRBS year, then a profiles year. And profiles, as I mentioned, captures school health policies and practices. So what is the school environment doing, again, to support or promote the health and well-being of students, staff, families, et cetera. And there's a number of different content areas, as you can see on the left-hand side, right? So there's questions about health ed, there's questions about physical education, health services, school environments, all types of different kind of school health related facets that a school district might be engaging in. And what we have predominantly used profiles for is to look at what are schools doing with regards to sex ed and what content are they teaching, right? Because that's always the million-dollar question of like, are schools providing sex ed? Yes or no? If they are, okay, what are they teaching? What content is showing up in the curriculum for students? And so this is a screenshot of an analysis that we've done where we looked at 10-year trends on what exact condom content was being taught at both the middle school level and the high school level. because we want to know, are students just getting kind of rote memorization facts about condoms, or are they getting information about how to use a condom? Where do I access it? How do I negotiate it with a partner, right? Those more kind of skills-based components of condom instruction. So from this analysis, we saw, right, that we actually see that secondary schools are moving in the direction of kind of how to use condoms, where to access them, a little bit more skills-based, as well as they're starting to talk about and include this idea of dual use or dual protection. So the importance of using a condom plus another contraceptive method, right? So we saw that both at the middle school and high school level. We also saw in this analysis, though, that for much of the high schools in the sample, they actually have had no change over the last 10 years, right? Which could be good. So if they have high prevalence of good condom instruction, there's no change is great. If they have, however, lower, or they're not including condom instruction as prevalently, and then in this 10-year analysis, we don't see any change, that could inherently be problematic. So you can use, this is just one example, but you can use profiles to get a little bit more information about kind of the content of what might be happening in health education or sexual health education across a number of different topic areas. So there's similar items in the substance use space, violence, injury and unintentional injury and violence. So just a sample of kind of the types of things. But for us, we're always interested in using profiles, again, to answer the question of like, okay, but what are schools doing? What content is being taught? And what content are schools providing to young people that we then use, right, in collaboration with our YRBS data that tell us what students are reporting in their sex behavior to see if there is congruence or discongruence, right? Okay, so that's like a big data dump. Again, main points there. I think it's important to check out YRBS, explore, look at profiles, and know that we've been tracking adolescent sexual risk behavior for a really long time, and we see it ebb and flow. That helps us not only think about our programmatic work, but also future research. So now I'll share a little bit about kind of our approach to school-based HIV and pregnancy prevention through what we call the What Works in Schools model. So this is a picture of what works in schools, and we read it kind of similar to like a logic model, right? So we start on the left. The stuff in green on the left is what goes into the model, and then we are working toward moving the outcomes on the right-hand side of the model, right, in the adolescent outcomes column. So as I mentioned earlier, we currently fund 28 large urban school districts across the United States to do this work. So with our funding, we actually provide funding to a school district. So we are the only place in CDC that funds directly to a school district, right? So we have colleagues, Sandra and others are working on other CDC funded dollars that go to state departments of education or state departments of health. Our money goes directly to the school district. And that is an intentional decision because we are interested in moving the adolescent outcomes. And so in order to get to adolescent outcomes, we've got to get our funding and programmatic work closer to adolescents, right? And the closest that we can get is to the school district level funding. So our money goes in, we fund a staff person. We also, with our funding, provide a network of national non-governmental organizations or NGOs who provide support. We also do a lot of technical assistance provision. I was telling Dr. Ross this morning, I'm on the phone a lot with school districts across the country trying to help them think about, okay, what needs to be included in their sex ed? What's not working? They're having community opposition, right? Like, how do we navigate that? So we do a fair amount of technical assistance and kind of capacity building directly to schools, which is arguably like some of the most fun part of this job is like getting on the phone with the school district in Iowa and saying like, we need help. We can't figure out how to get this condom issue in our schools. Like, what do we do, right? So we do a lot of that work. Our funding goes directly to the education agency, as I said, and with that money, the districts typically hire a coordinator or some type of person or small group of folks really to be that coordinating body. So they're usually in like health and wellness departments. Sometimes they're in student support services, or they might be like in a health and physical education department, but they're really there to coordinate activities, right? They are the logistics person or persons that then oversee 3 primary strategies. So if you look at the schools kind of column, that person is then overseeing the implementation in schools of 3 main things. So one of our strategy areas is quality health education, which is kind of my content area, right? And the sexual health education falls there. We also ask that our funded recipients provide links to services. So how are they either providing on-site health services through a school-based health center or some type of wellness clinic, or how is the school district linking students or referring them to a community-based provider? Because we know that services is a key piece of this puzzle. You can't just teach people about condoms unless they have access to them like we have to have both, right? So it's a both and. So we've got to have the linkages to services. And then our third strategy area is the safe and supportive environments work. And in that bucket, it's all of our work around LGBTQ inclusivity, school connectedness, positive youth development, and programming and training for staff and students around how to create affirming and safe spaces in the school where young people can thrive. Okay? So all of those things together move us in the direction of the outcomes that we are most interested in measuring over time. So we're interested in seeing reductions in sexual risk, reductions in substance misuse, increases in mental and emotional health, and then decreases in suicide-related behaviors and experiences of violence. Okay? So those are kind of the five primary buckets where our money is working to move. And in a good way, we do see that our program evaluation does show those intended improvements, right? So in school, and we have a citation here. I'm happy to provide additional papers, but we've done a number of analyses that show the impact of when schools are providing, when they're provided funding and when they are implementing these three strategies, right? So health ed, health services, and safe and supportive environments. We see population level impacts in two ways. So we see improvements in mental and emotional health, specifically for LGBTQ students, right? So our sexual gender minority students, and we see lower rates and prevalence of sexual and the other categories, right? Sexual risk, substance use, suicidality, and violence for our general population of students. So we're really excited about these evaluation data that do suggest that this programmatic approach, right, which looks like this, that when you provide these supports, both technical assistance and funding to a school district directly to implement a set of strategies at the school level, we can see outcomes, again, population level outcomes for adolescents, which is really important to one, not only continue the funding that we have, but also to create an evidence base that shows what works in school settings, hence the name, right? So our evaluation data, we're really proud of it. We're really excited. We are right now in year 6 of our, what was a 5-year funding cycle, but we extended a year because of COVID, right? So we're in year 6 of a final funding cycle, and then we're really looking forward to getting that summative data from this current cooperative agreement funding to see if we can kind of replicate some of these similar results and see what we might find in terms of trends in these health behaviors over time. Okay, so that's, again, the programmatic approach, what works. I talked a little bit about the program evaluation. Now I want to speak just a little bit more specifically about the sexual health education work. So we're kind of working in a funnel, right? So we know that sexual health education is a discipline and is a programmatic strategy that can help young people acquire knowledge and skills that they need to be not only successful and healthy, but lifelong learners in and out of school. So there's a robust evidence base around why and how sexual health education works. And there's a number of things that schools can do. As I said in the beginning of this talk, right, we're solely focused on schools, but we know that that is just one of the venues and avenues by which young people get health information. Show of hands here, how many people had sex ed in their K-12 experience? Yeah, okay, the people with the hands down, did they not get it? Everyone's like, no, it was so bad. No, okay, good, no. Oh man, okay, that bums me out. But I am encouraged to know that most people got something, right? So there's a number of things that schools can do, right? So schools can build capacity for staff that are specifically delivering sexual health education, and we see that predominantly through training and professional development, right? So you've got to train teachers and facilitators in how to deliver sexual health content. They can also provide and teach functional health information that is related to HIV, STI, pregnancy, and related outcomes. And as I mentioned earlier, it's a really, really important piece of this educational component is linking students to services, right? So how do you train staff to conduct referrals, warm referrals, soft referrals, or how do you empower and create a skill set among adolescents so that they themselves can navigate healthcare settings, right? Because we know that that is a huge issue in terms of it's one thing to access health services. It's a different thing for young people to have the skills and the literacy to be able to use the health services either by themselves or in accompaniment with a parent, guardian, or mentor or trusted adult, right? So there's really the health services piece. We have to have access, but we also need to have skills in order for young people to make those decisions for themselves. And through quality health education or sexual health education, right, depending on the content area, we're really working in service of 4 main goals. So when young people exit their K-12 experience and they have had health education or they have had sexual health education, we really want them to be able to do 4 things, right? One is make health promoting decisions, right? They have to have knowledge and skills in order to be able to execute, to identify, execute, and reflect on a health decision, right? Do I wear the condom or not? Do I drink this beer before, during, or after I have intercourse with somebody, right? Like how they actually make decisions around sexual reproductive health. We want them to achieve and maintain health literacy, right? So we know health literacy to be this idea that anyone, for us it's young people, but that they can obtain, use, and apply health information to improve their health and well-being. And so we want them to be able to know how to do that, how to access info, analyze influences, and make decisions. Number 3 is probably the most important one for us. We want them to adopt healthy behaviors, which is also the hardest one to do, right? Because sometimes young people get 1 week of health ed, or they get 3 lessons of sex ed in 9th grade, and then we want them to use a condom consistently and correctly every single time they have sex with a partner, right? So adopting healthy behaviors is the hardest one. It's also the most important one, because we know that once adolescents develop healthy habits and behaviors in adolescence, that does translate to adulthood, right? So we want to build those foundational skills now, build those foundational health behaviors now so that can carry them throughout their life course. And then we also want them and encourage that they are promoting the health of others, right? So not only am I an advocate for myself, I can then advocate for others in my community, in my school, in my family, et cetera. So for us, when we think about sexual health education, we're really trying to get students to these 4 outcomes, right? And within that, we then see things like we want them to regularly test. We want them to wear condoms. We want them to negotiate. We want them to be able to report or identify when they have experienced a sexual violence encounter or an act by a partner, right? But these are the 4 main outcome objectives for us. We're always curious of does it work, right? So does HIV, does sex ed work? As I said before, this is a really, really densely studied content area. A few studies to highlight here. So I think one of the things that in our kind of subfield of sex ed, one of the calls for a long time has been, how do we ensure that sexual health education is inclusive for all students, and particularly for students with gender and sexual minority identities, right? And so what we did with this data, this is from the National HIV Surveillance data, set specifically for young men that have sex with men, so they have a sexual minority identity or status. You can see the age group here, and we were interested in looking at, is there an association between exposure to HIV in school, so in their K-12 experience, and reductions in sexual risk behaviors. And we, fortunately, did see some really impactful and important findings here. The last bullet really being that among sexually active adolescent sexual minority males, we saw that those that were experiencing or had an exposure to HIV ed in school were less likely or had reduced odds of reporting both an STI and condomless anal sex with their last sex partner, okay? So these data suggest to us that when HIV education is provided, we do see some protective effects on these risk behaviors, again, STI and condomless anal sex. Now, the caveat with these data, and I think a lot of data in the sex ed space is, well, what about quality? Well, how do we know what kind of HIV ed they got? Well, we don't. From this data set, we don't know, right? So for us, the first step is always to be able to document, okay, does that exposure exist? Does that relationship hold? And then the next iteration of the questions and the work is, okay, well, how do you define quality? Because there's a lot of variation in what HIV education could look like. And if I asked everyone in the room, what was the quality of your sex ed experience, would probably be markedly different for every person in the room, okay? So I think one of the things that we're really trying to grapple with is, how do we identify quality, or how do we quantify that thing? Who defines quality for whom? And that's one of the questions that we're really trying to think through right now. Like, we have some science that will tell us some characteristics of quality, but we know that those are going to also in and of themselves be somewhat limited, because your lived experience as someone that receives sex ed is probably going to be markedly different than mine, right? Depending on where I live, what my context is, what knowledge I have coming in, who my teacher was. So trying to really think about these indicators of quality is like a sticky point that I think our scientists are wrestling with. The other recent publication, I apologize, this is so small. The other recent pub that we have worked on and published was a lit review that asked specifically sexual and gender minority students about their experiences in school-based sex ed. And probably not surprisingly, we found in the study that their experiences were not great, right? There were lots of things that they wanted to be different. There were lots of issues that arose in the papers that were included in this review. So a few things to highlight, just some arrows, right? So when SGM students were asked about their school-based experiences, they note in almost all the studies that the sex ed that they got in school excluded information related to sexual and gender minority identities, right? So that their sex ed experience was very heteronormative, it was cisgender focused, and if you didn't fit into those binaries or those pre-described identities and you weren't having penis and vagina sex, you basically don't exist, which we know is not how the world works, right? So again, it's important for us to be able to document these issues, though, so that we can think about how do we create more inclusive sex education that does get delivered in schools. So it was totally devoid of SGM identities. Students want more relatable instructors, right? So they want instructors that, one, not only look like them or have a salient characteristic, but also are open, affirming, and really are accepting of all the ways in which their young people's sex and identity show up in the classroom, which we know is vast. They also comment pretty consistently on this idea that sex ed that they get in school is really focused on risk and nothing else, right? So it's just, I always think back to that Mean Girls clip, right? Where they're like, the gym teacher's like, if you have sex, what does he say? You will get chlamydia and die or whatever, right? Like this is kind of what they're talking about, right? It's like, if you have sex, chlamydia, it's over. And we know that like, that's not how it works, right? So really trying to think about in our sex ed programming and even in our research, honestly, how are we capturing other facets of sexual being, right? Pleasure, sex positivity, relationships, violence, right? Again, this morning, I was so grateful to sit with Dr. Ross for so long. You know, one of the things that we were talking about was for a long time in the sex ed space, we've been really hyper-focused on measuring condom use, pregnancy rate, STIs, and that's basically it, right? Like as a funder, that's what we're asking folks to do. Researchers are reporting on those outcomes. But when you hear from young people, they're telling us that they need information about lots of other things. They need information about how do I navigate consent? I have no idea how to do that. My partner doesn't know how to do that. So consent for us is a huge growth area. Another area is around relationships. So just how do I show up in a relationship with another person that I may or may not even be sexually involved with? That just we're going to coexist as human beings. What kind of relationship skills can I have, or do I need rather? So consent is big, relationships are big. Sexual violence is another really big area that I think in reproductive health, we've been a little bit siloed from sexual violence, and we know that those two experiences are overlapping, right? Experiences of violence as well as sexual behaviors. So trying to think about what does that mean and what does it mean and what does it look like for different groups of students? Right, so what does it look like for your heterosexual students? What does it look like for students that have sex only with the opposite sex? What does it look like for transgender or questioning queer individuals? That all looks and can be different. And those overlapping identities are related to how their experiences in sex, violence, and these other co-occurring areas manifest. So we're really trying to think about, and these data help, I think, confirm this issue that we have got to move beyond just this really strict and narrow focus on what is sexual and reproductive health and make sure that it is inclusive and it encompasses the lived experiences of all the types of students that come through the door in a school-based setting. So if you're interested in learning about any of the kind of our approach, I've just given you a really quick high-level teaser here, but we do have a document called the PS 1807, PS 1807 program guidance. And in this guidance document, it goes into way more detail about everything that we want schools to be doing with regard to sex ed. It also talks at length about what we are expecting or wanting in the health services lane, as well as the SSE or safe and supportive environments lane. So you can kind of get a flavor for, again, with our funds, what our 28 school districts are being asked and required to do. And it's based, as you can see there, on scientific literature and expert feedback from folks in the field. Again, all around the idea of reducing HIV, STI, and pregnancies. Okay, so that's a little bit about our approach. The last thing I'm going to talk quickly about is tools and resources, and then I'm sure people have burning questions in the room, right? So I'll take any and all of those. So if you don't take anything else from the talk, I think the most important thing is to check out our website. Has anyone ever been to the DASH website? Yes. Okay. 2, 3 in the wild again. Y'all are great. So if you just Google CDC Healthy Youth, you can find us, right? Or you go to cdc.gov/healthy youth. All the stuff that I showed you today can be found on the website, plus a million and one more pieces of information, data, resources, tools. We have there's like an info@CDC. So if you have a question, if you want to submit a question to CDC Dash, sometimes I always tell people is like, if you submit a question to CDC, it actually comes to someone's inbox. Like I get a lot of public inquiry questions. So if you submit something and you have a question, it will go to a human being that will be able to hopefully provide you an answer, right? They're not bots or robots. I mean, they're like human answered questions. So again, if at any point you have a question, you can reach out to me directly, or we've got info boxes at CDC. But check out our website. It's chocked full of information and content. Specific to health education, which again is kind of in the funnel, kind of my content area, we've got a number of resources all about what schools can do in the health ed space. And then we've got more pages about what they do in the sex ed space. But on our website, on that left-hand navigation is like where you can find things. I'll also be the first to say that our website is a little complicated. I'll just say that in transparency. So if you're ever lost, like go to the left-hand nav. That will, hopefully you can find your way back. But ours is under health ed, which makes sense. And under that, you can see more information about our approach, right? So what we ask school districts to do, and then lots of tools and resources. Because again, as I said, one of the primary goals of CDC is to create tools, resources, and guidance that the general public can put the data we have into action to protect and promote the health of Americans. So a couple resources for school-based sex ed, just so they're kind of on your radar. One is our characteristics of effective health education curricula, or the kind of 15 characteristics is what it's known for. So this is a research synthesis that looks at across a decade of research in all types of content areas. So sexual health, violence, substance use, abstinence, like all the health topic areas. We did a review and looked at, okay, among all of these effective interventions that show, right, at least one statistically significant impact on health outcome behaviors, what are the shared characteristics of those curricula or those programs? What do they have in common with each other? And from there, we've created this characteristics document. So as the title would suggest, these are the shared characteristics. I will say that we are actually in the process of updating this characteristics review right now. We have a contract that we're working on it. So I would anticipate in the next year to year and a half, this will be updated with based on new available science and research, which is exciting. We've got lots of resources around scope and sequence, which we won't go into, but scope and sequence is basically a curriculum tool that helps schools think about, okay, what do we want to cover and in what order, right? We want kids to get these 5 units, and this is the order of the units. This is what they get in 5th grade. This is what they get in 6th grade. This is what they get in 7th grade, right? So we've got scope and sequence resources. And the other thing to note, so we've got pacing guides and unit planners. One of the pieces that I think in DASH take very seriously is hearing from the field themselves, right? So like this last tool on the right, this came out of a direct request from a middle school teacher that came up to us at a conference and said, I don't have a pacing guide. Like, can you create something, or is there a template, or I need help because my school district doesn't give us this resource and it would be really helpful to me. So we were like, absolutely. So hence the pacing guide and unit planner. So we've got resources for lots of different types of folks that work in a school, both administrators all the way to the classroom teacher. And we try to always be really responsive to hearing from the field in terms of what they need, and then creating those resources alongside them or in collaboration with those practitioners. So again, a bit of a flavor of some things that we've got. Probably our flagship tool in health education is the HECAT. Any HECAT fans in the room? Nobody? Oh man, okay, y'all. That makes me sad. Okay, so the HECAT is, and I could do a whole nother talk on HECAT, which I won't, but it's the health education curriculum analysis tool. And you can see there, we last updated it in 2021, so it's kind of new at this point. And what it is it's a free tool that any person, a school district, a community-based organization, if you're a healthcare provider, you develop curricula, you can use the tool to assess any kind of health ed curricula. So we oftentimes see school districts, like, they might come to us and say, okay, we're considering curriculum A versus B, which one should we choose? Right? And what we don't know, we're not in the school district, we don't know your students and staff, but what we do encourage is that they use this systematic evidence-informed tool to run both of the curriculum through that analysis. The tool will spit out tailored reports. It will tell the user kind of what are the strengths of the curricula, what are the omissions, what's missing, et cetera. And we see that folks use this on all types of curricula, whether it's commercially available. So maybe they got a grant and they're going to implement an evidence-based intervention and they want to see how that EBI scores in HECAP, or we see it used with districts that are creating something brand new. They're like, we've got some time in the schedule. We're going to create a mental health curriculum, for example. Where should we start? And we point them to HECAP. So again, as I say on every slide, check out HECAP because it is one of our seminal tools, and we did just recently update it, which is exciting. Talking about updates, one of the modules in HECAP is the sexual health module, which makes sense, right? Because that's one of the kind of domains and content areas. And we did a number of revisions in 2021. Previous to that, the tool had not actually been updated in like 15 years, so it was a really long time. So the science had come a really long way, right? So in this recent update, you'll notice things like, right, there's much more inclusive anatomy and puberty concepts and vocabulary. There's ungendered language, right? So instead of male penis, it's person with penis, that type of thing. So to ungender both sex assigned at birth from gender identity and expression. Concepts related to, as I said, orientation and identity, technology, as well as a number of additions and revisions to both the STI HIV treatment and prevention pieces, right? So we know over the last decade, for example, in HIV prevention, PrEP and PEP have come on the scene as prevention mechanisms for populations. And so those types of additions have been added to the 2021 version. So we're really proud of it. The tool does include 4 grade levels. So that's often a question we get asked is like, what are the grade levels? And there is content in the sexual health module, for example, for grades K to 2, 3-5, 6-8, and 9-12. So those 4 grade bands are included in all the modules in HECAP. You can access it online. So there's an online version, which is exciting. 2 other tools to point out quickly. So in the health services lane, we have something called the Get Yourself Tested, which is a public kind of health awareness campaign resource and tool that has been studied by some scientists at CDC really to raise awareness and knowledge around STI and HIV testing. So we've got toolkits, as you can see by the screen capture, student workbooks, and we work with school districts often to implement the GYT program so that they can build awareness around testing. Sometimes this resource itself will lead to school-based testing events, right? So they'll do STI testing either in a school-based health center or a wellness clinic or somewhere on site, again, for that screening and treatment, screening and testing, and then linking students to treatment and care. The other resource that's interesting, and this is actually newer for us at CDC. So over the last several years, we have been doing a lot of work in the classroom management space around kind of what practices do teachers engage in or not, and then how do those practices relate to school connectedness, right? So we know the school connectedness from a robust body of work is associated and protective against a lot of health risk behaviors, right? And this idea of connectedness being how close do I feel to others at my school, whether it's a teacher, another student. So those measures of school connectedness are captured in our YRBS data. And we are also really interested in looking at the link between what are the practices that a teacher might do in the classroom and how does that improve or increase or decrease students' levels of connectedness. So from a systematic review that was published, I think maybe in 2021, we identified a number of strategies. So there's actually a lot of things that classroom educators and arguably anybody in a school setting could do in order to manage classroom or settings where students are gathered and improve their school connectedness report. So this resource you can see on the right-hand side, we've created a number of fact sheets that you can access and download that talk about, okay, what is the strategy? So one of the strategies is like, facilitate connections between students. That is a classroom management strategy, right? So if I'm a classroom teacher and I know that I have to facilitate connections between students, but I go, how do I do that? what does that look like in practice? We've created a number of fact sheets that actually talk through very practical steps, right? So maybe as the classroom teacher, I might allow students to choose their partner, right? Or if we're going to do some kind of small group work. Or I might use kind of get to know you type of activities so the students can start to build some authentic connections with peers that they may not have otherwise connected with outside my classroom setting. Things like that, right? So the classroom management one-pagers are really helpful. They're designed for a teacher audience. So they're for educators, again, to look at, print out, keep on their desk to say, okay, if I'm trying to increase the management of my classroom so that I can work toward allowing students to feel more connected, what might I do? And then the last thing is we have a huge portfolio of work around supporting students with LGBTQ+ identities. And I only just gave you like a really high level today. But we've got a number of tools and resources, the first of which being a self-assessment tool, which is at the top. And that's a tool that we created for school staff. So it could be anyone in a school, an administrator, a school nurse, a teacher, a paraprofessional, custodial staff, administrative staff, to really take a self-inventory of how inclusive are the practices that I engage in my behaviors every day, right? And so in the tool, there's a number of questions, and the user will go through answering the questions, and then at the end, they get a set of tailored resources, right? So here's some things that will improve my inclusivity practices. Here's some resources that I can use to keep going in my inclusivity work. It's not evaluative in the way that, like, if you score 5 versus 10, you're good or bad. It's just a way for school staff to, again, take that kind of self-assessment of where am I in terms of implementing inclusivity practices that we know help and are beneficial for students with LGBTQ+ identities, plus general populations of students in the school. And then the last thing is all about professional development. So one of the things that hopefully came through at one of this is we can provide lots of tools and resources for schools, but a huge piece of this work is professional development and training, right? It's not enough just to give schools 400 resources and say, good luck. Like there's a huge training burden that comes with this, whether you're talking about sexual health, whether you're talking about inclusivity, whether you're talking about management, right? So training is a really, really big piece of this puzzle. And so in our LGBTQ space, we have created some resources to help schools think through professional development planning, professional development objectives. What should I include in a training about LGBTQ health, right? Like what are some topics I should be talking about with my staff and educators? And so that resource is, again, available to kind of help schools think about and plan PD for inclusivity. So that's just a really high level of lots of tools. I've now been talking for way too long. So I'm happy to answer questions. Again, I'm happy to connect after this offline, share email. I always end presentations with, I think it's important for folks to know that at CDC, we work on behalf of you all, right? We're paid with your taxpayer money. And so use us as a resource, right? We try to keep really dense connections with folks in the field. I'm so excited that there are so many students here and like future professionals. If you're interested in working at CDC, I don't make enough money to make any calls, but I'm happy to talk with you about that because that's oftentimes one of the avenues that students want to know, like, how did you get there? How did you get inside, right? But I think it's important to just know that like we are working on behalf of you, so you have to talk with us. And we are always trying to be responsive and think about what are the needs of folks that are doing the work on the ground much closer than we are, right? I'm not in a school every single day. Some of you are, right? And so what are you seeing? Help us kind of work collaboratively and work together in the space to use schools as a venue where young people can thrive, right? That's really at the end of the day kind of what we're trying to do. So with that, thank you so much. What questions do you have? Oh, we already have one too. Okay, yeah, please.
Do you want to take them yourself or do you need help?
Oh no, I got it. I think I can handle it. Okay, what's your name? Tell us who you are.
Yeah, my name is Lucas.
Okay.
And one question I had, so when you're talking about that model and how it's kind of implemented within the school system,
Yeah.
and then you mentioned a little bit about some communities are more apprehensive to that model.
Yeah.
What sort of changes do you use for implementation of that model, or are there any changes at all when you're dealing with a community that might be more apprehensive to something like sex education?
Yeah, okay, so that's the $1 million question right off the bat. Good job. Okay, so there is community opposition to sex ed. It would be false of me to say like kumbaya, everyone is like wants to do sex ed all the time. which that's not the case. And there's actually huge variability district to district. I think one thing that often, and I'll get to your question, but one thing that people assume is like, oh, this is a blue state, so like everybody's cool with all things sex ed or orientation, like everyone's just like cool with it. That's not the case. Even in the most liberal of places, you have school districts that experience really, really heavy and real pushback on, it could be anything. It could be talking about condoms. It could be the word sex is like no-go in some communities. So what we try to do, our default is always the community knows best, right? I don't live in that community. I'm not in that school. I don't have any real deep context on what's going to be appropriate or not appropriate. Now, our role is to be as encouraging as we can and say, okay, but here's what the science is telling us, right? We know that sex ed needs to be inclusive. We know that it needs to include information about identity. It needs to link students to care. It needs to provide condom education and instruction. And to the best that we can, we try to work with the capacity of the district staff to try to create and leverage those messages. That doesn't always work. And in some places, some pieces of sex ed can't be done, right? They can't do condom demonstrations in their school. They can't talk about transgender issues, which is really hard because we know that that is a reality for millions of people that walk around. So I think our program, it is flexible in that like we have to kind of take the lead of the districts and the people on the ground to know what is best and intervene only when we see potential harm, right? But that's a really thin line that we walk in terms of providing and continuing to give guidance, to continue to give science-based guidance, while also recognizing that in some communities, they're just not ready. They just are not ready for transgender issues. Like that's just as an example, right? Or they can only provide mental health services, not reproductive health services, because their current climate or the current opposition, real or perceived, is too great. And so I think and then one of the nice things is our funding cycles are 5 years. So we build some really deep relationships with schools, right? We're not just like parachuting in for 1 week and then like piecing out. So we're really walking with them in this 5-year period and can kind of help them navigate some of that. Yeah, but that's $1 million question. It looks different in every school district, I think, based on the community context. Any other questions? Oh, yeah.
I'm Mackenzie. Hi.
Hi.
If we're in a school district that's not, it's not one of the like selected school districts and it doesn't have like the health coordinator person hired, but we still want to use like the resources and different pieces of the curriculum things. Is there like a training that someone from the school would have to get through the CDC? Or can we just kind of like take the stuff on the website and go for it?
Yeah, no, take it and go, take it and run. So that's kind of a double-edged sword, right? So all the resources we have are totally free and accessible to anybody. So you don't need a school health coordinator. You don't need to be funded by DASH to use our tools. And we hope that lots of school districts use them. We do provide, though, like if you need some training, like if you need, for example, HECAT, right? Like if someone in your district or you're in a school and they're like, we think we want to try HECAT, but the tool's massive, so we're not really sure. You can always call us and we can provide some kind of short-term, kind of compact training, but there's no prerequisite or requirement. You can use all the tools that you want, and we are available to, either us or some of our partners would be available to help you kind of train and get people up to speed. But no, there's no gatekeeping on the tools and resources. Yeah.
Can I hear our last question, or does somebody else have? No, we're coming up on time.
We got one right here.
Oh, go ahead.
Yeah.
I'm Remy.
Hi.
So how would a school go about getting funding for DASH if they were?
Yeah, okay, so that's a more than 1 minute answer. So our funding is put out in a call for proposals, right? So we will forecast that we're gonna have a 5-year funding cycle. And the best place to look is to look on grants.gov, and a school district would just apply based on the funding announcement. And then there's a selection process and a review process for which school districts could potentially receive our funding. But it's through grants.gov, and we will put out a public call for when our funding is available.
Okay, thank you.
Yeah. Oh, good question. I know we're right on
I
time,
think
so.
we're at time. I'm gonna
Okay.
ask my question.
Okay.
And it ties back onto Lucas's question.
Great.
So what's going to happen, or what are the proactive approaches you're taking with YRBS as some states are now pulling out?
Yeah.
So Florida has, our great example, I was on some media interview with them.
Yeah.
They're not allowing
Yeah.
YRBS, but they made their own.
I'm not going to comment on the latter part.
Okay.
Yeah. So yeah, so we are, I think right now experiencing in the world of surveillance really unprecedented times where states and school districts are pulling out of YRBS for a number of different reasons, right? So sometimes it's the items around sex. That tends to be kind of like where the rub is. States don't want schools to be asking students about their risk behaviors in sex. So for us at Dash, I mean, the most proactive thing that we can do is kind of two things. So one, it's that we are trying to talk to anyone and everyone about the benefits of collecting youth risk data, right? Like, we can't do anything else around programming or providing support, prevention, unless we know what the issues are. And YRBS is like a seminal way that we document what the issues are, right? So the importance of YRBS data can never be undersold, I think. And so we are always talking to people in the field about this is important, why it matters, why, for example, asking students about sex does not make them start having sex. Like, we hear that often, that like, if you ask kids if they use condoms, they're just having sex with everyone. And we're like, it doesn't even remotely work that way. But okay, so there's a lot of that like myth busting, I think, that happens. So we are always trying to actively talk with folks. And to be honest, I don't think we know what's going to happen,
We don't know yet.
right? Like, we don't know. So we've seen Florida, Iowa. There's lots of places that are withdrawing from YRBS. And the best that we can kind of leverage local partnerships, other groups, researchers that are using YRBS data to continue to beat the drum of YRBS is important and critical to public health and to the well-being of young people. Is at this point kind of the best that we can do, right? I think the other thing that's important to know about YRBS is that states decide what YRBS questions get asked. So state coordinators are the folks, I mean, we are certainly always trying to advocate and, again, sell the whole system, but really states and state coordinators in your departments of ed or your departments of public health are really folks that make decisions about whether surveys happen, what items happen on surveys. So for us, like, of course, we want every state to be participating in YRBS, but we don't actually have final say. It's state coordinator voted. So I think it's also being plugged into who in your state has leverage and influence on YRBS, because you're right. I think going forward, it will be a bit of the wild, wild west until we can figure out what's going to happen.
I know my
Yeah.
question is over time.
No.
I want to thank
Thank y'all so
you to be
much.
here forever, and I'm sure you'd be happy to stay and
Yes.
answer questions
I'm
for
happy.
those that are online and those that have to go to other classes,
Yeah.
not my students. And we want to thank
Oh, yeah.
Laboratory School of Child Health. Thank you so
Thank
much.
you. Awesome. Thanks, y'all. Be safe. Thank you. Yay.